Good morning. My name is Hassan Murad. I am a professor of medicine at Mayo Clinic, and I direct the Mayo Clinic Evidence-Based Practice Center. I am a clinical epidemiologist, and my area of interest is guideline development. In this talk, I will start by giving you a quick background and discuss the implications of using non-randomized studies and real-world evidence in decision making. Then I will touch on 8 related clinical epidemiology frameworks or themes that are important to those who are interested in using non-randomized evidence for decision making. We all know that randomized controlled trials remain the gold standard in biomedical research to assess efficacy. James Lind in 1747 perhaps conducted the first trial in which he discovered a treatment for scurvy, which is vitamin C deficiency. Subsequently, there were several randomized controlled trials in the fields of psychology, education, agriculture, and others. And perhaps the most clear description of a randomized controlled trial was the one by Austin Bradford Hill for Streptomycin as a treatment for tuberculosis in 1948. Now, why is this? Why are randomized controlled trials the gold standard or the best way to assess efficacy? There are two separate distinct mechanisms. The first one is just due to randomization, which balances known and unknown prognostic factors between the two study arms. A separate mechanism is allocation concealment, which reduces selection bias. Allocation concealment is the process by which the person assigning patients to the two different groups is unaware of their destination or of their allocation. So it's different from blinding, although a lot of people get the two confused. But these two mechanisms are why randomized controlled trials remain the gold standard. However, this concept is challenged, and I will give you an example. So, a randomized controlled trial that compares prednisolone versus acyclovir versus placebo for Bell's palsy. This trial shows that the winner, prednisolone, has the highest likelihood of recovery. However, when we look at the inclusion criteria of the trial, we see that patients with confirmed diagnosis by a senior otolaryngologist is what actually included in the trial, and this diagnosis had to be made within 72 hours after the onset of symptoms. If we look at what happens in the real world, Bell's palsy is usually diagnosed by a general practitioner in a primary care setting with a very rare access to an ENT physician within 72 hours. Therefore, it is hard to apply the results of such trial to daily practice. Another example, ventilation with lower tidal volumes was found to reduce mortality in patients with acute lung injury, or what's called ARDS. This is in comparison with ventilation with higher volume. The trial that showed this was performed in academic centers with advanced intensive care units. The trial used additional equipment beyond usual care and beyond what's available in the hospital. None of this equipment was planned for at the beginning of the trial, and therefore it's really difficult to implement that intervention in hospitals that have the capacity of 100 to 200 beds. You can see that it was difficult to implement it in an academic center, so that it will be really hard to implement at that time in non-academic centers. What I have described thus far is the spectrum of pragmatic versus explanatory trials. It's very well known. It's also described as mechanistic or practical trial. So mechanistic versus practical, or pragmatic versus explanatory. I show here a picture of a tool that can be used to determine how applicable or how pragmatic a trial is. So you can see the different domains, such as things that relate to the eligibility of individuals to be enrolled in the trial, the recruitment process, the setting, the organization, the flexibility in the delivery, and adherence to the intervention, and so forth. So this is well known, and there are tools to evaluate it. So how common is this? In an unselected population of patients with chronic obstructive pulmonary disease in an outpatient setting, it was found that 83% of those patients were actually ineligible for inclusion in COPD trials. So the majority of patients in real practice do not really fit the trial inclusion criteria. Similar results were shown in other fields such as cardiology, oncology, and mental health. In general, patients who were enrolled in the trials tend to be younger, tend to be more likely to be male, they have minimal comorbidity, and are highly functional. So the need for non-randomized controlled trial or observational studies arises, and this is one rationale for that is the challenge with applicability of randomized trials. From a classic epidemiology point of view, if we compare randomized controlled trials to observational studies, we have all, I'm sure, seen this before, but if we look at the first row in this graph, which is risk of bias or internal validity, randomized controlled trials usually have a low risk of bias, whereas observational studies will have a high risk of bias due to confounding, selection bias, and missing data. If we look at applicability or external validity, randomized controlled trials usually have low applicability because their patients are highly selected, as we just discussed. The doses of treatments are fixed, and there's close follow-up and more fidelity to the intervention. Whereas in observational studies, there is high applicability because of the wider inclusion criteria, the loose dosing regimen, and the real-world follow-up procedures. If we look at really what fits a real-world evidence, so randomized trials is likely to say no for that, unless they were designed to be pragmatic or practical, and particularly like if it was a cluster trial. In terms of observational studies, then it is likely to more represent the real-world experience. And generally in epidemiology books, you read that in terms of use of the evidence, therapy, the gold standard there is randomized controlled trials, whereas observational studies are more informative for harm or adverse effect. That's because they are larger, so they can pick up rare side effects. They have longer follow-up, so they can pick up side effects that take time to develop. And they enroll or include less selected patients, so they have patients who are more likely to have adverse effects. How about the results? If we compare observational studies to randomized controlled trials that are trying to answer the same question. Many studies have actually compared randomized trials to non-randomized trials. And in some comparisons, we've seen that 11% of the time the effect size of the observational studies was outside the 95% confidence interval of RCTs. So 1 in 9 observational studies will give results that are completely different from an RCT. In another evaluation, 1 in 18 trials in critical care medicine in which a propensity score matching was used was different in comparison with randomized controlled trials. So in 1 in 18, there was important difference or significant difference between the observational study and the RCT. In a meta-analysis, which is a meta-epidemiologic study that evaluates meta-analysis, the ratio of odds ratio was 1.08, which means that observational studies tend to exaggerate the effect seen in randomized controlled trials, because the ratio of odds ratio is above 1, so it tends to exaggerate. However, the confidence interval crosses 1, which tells us that there are occasions that this doesn't happen, and so basically we don't know for sure whether the effect is exaggerated or underestimated. So in summary, randomized controlled trials will give results similar to non-randomized controlled trials most of the time, but not always. And we cannot tell when, which is the main problem. So the main issue is that we cannot tell when this difference will exist. In this study, there were comparison between RCTs and non-RCTs. There are two panels here. One is for cardiovascular treatments on the left and one for non-cardiovascular treatments on the right. If we look at the plot, it shows you the point estimate and confidence interval of RCTs and of those studies that were non-randomized, but they are trying to answer the same question. So if we look at these, we see that they are consistent most of the time, except perhaps in the middle of the plot on the left when we look at CABG versus PTCA in patients at low risk. We see that the observational study estimate is quite different from that from randomized controlled trials. If we look on the panel at the right, which is the non-cardiovascular treatment, we see that they are consistent almost most of the time. But again, the problem is that we cannot tell when. We cannot tell when they will differ. Two recent rationales for using non-randomized trials. This is aside from what I mentioned to you earlier, which was pragmatism or issues with applicability, cost. The randomized trials will be more costly, and the sample size and the duration. So aside from these issues, two additional rationales. One is the explosion in data sources, or what's called big data. So we have big organizations and health systems using electronic health records, generating administrative or billing data along with clinical data. There's also explosion in data coming from social media, from smart devices that monitor activity and other things, and then other census data and environmental data. So there's a lot of data, so we gotta use it, right? So that's one rationale for trying to not only depend on the randomized trials. Another rationale is the learning health systems, which is a new concept. So these are defined as systems that are designed to generate and apply the best evidence. So the system generates its own data and applies that data along with external evidence. But the key point in a learning health system is that it learns from its own data. So that was another important development that will make us want to use the non-randomized evidence as well. So despite all that, the randomized controlled trial remains the gold standard. The FDA uses non-randomized studies for assessing harm and adverse effects, but it's very hard to pass on all this big data. It's a lot of data. And medicine actually is way behind other fields that use big data, such as the web industry, security, insurance industry, and others. So we need to just find a framework that we can use this data. And just to explain some terms here. So I've said during my talk, and I will use terms like observational studies. So observational study is a study in which there's no randomization, you're just observing. You'll hear non-randomized interventional studies, and sometimes people will call it observational trial or non-randomized trial. This is basically an observational study in which there was an intervention, but still it's not randomized, and from an inference standpoint, it's just like an observational study. When we use the terms like big data or real-world evidence, this implies that it's non-randomized, but it also has some other aspects of pragmatism. It is not generated by a protocol, and it's routinely generated and routinely collected in the course of care delivered. After this background and rationale, I will move to these 8 themes or frameworks or approaches that I want to tell you about, and they are related to this concept of using non-randomized studies for decision making. The first concept is GRADE. So GRADE is a modern and most commonly used framework that is used to develop guidelines. So guideline developers use it to rate certainty in the evidence and develop recommendations. And since its inception in 2004, GRADE very quickly recognized the importance of non-randomized trials. And based on the principles of evidence-based medicine, where decisions must be made based on the best available evidence, regardless of the study design, GRADE said that you should use observational studies. And in GRADE, study design is just one domain in this larger construct of certainty in the evidence. This picture shows the construct of quality of evidence, how GRADE defines that and shows how it can be evaluated. So when we're rating the certainty in evidence, we start with establishing an initial level of certainty based on study design. So you see at the far left of this figure that randomized trials have a provide evidence of high certainty, and observational studies provide evidence of low certainty. Then in the next step, you see that we can lower or raise our certainty in the evidence based on different factors, such as risk of bias. So if there's high risk of bias, we lower our certainty. If there's inconsistency among studies, we lower our certainty, and so forth. And then there are reasons by which we increase our certainty in the evidence. And eventually we reach a final level of certainty, which is on the far right, that goes from very low to high. In this framework, there are two areas that are relevant to observational studies, and I enlarge these two areas. The first one is when we talk about indirectness in GRADE. So does the evidence fit the question? So if I have a question in mind and I found a study that answers this question, is the patient intervention outcomes of the study, are they similar to those of the question? So this is the domain of the directness in GRADE. It's similar to applicability or external validity in some ways. So that's when the issue of observational studies come here. So in GRADE, if we see a randomized trial that is less applicable to our question or our decision, then we may use an observational study, and this observational study may turn out to have higher quality evidence than the randomized trial. So that's one issue. The second one is these areas that can lead you to increase your certainty in observational studies, and these are large effect, dose response, and then the issue of plausible confounding. I will explain them with an example. So in terms of large effect, so there were studies showing that front versus back sleeping for infants, whether they sleep on the front versus the back, increased the sudden infant death syndrome, or SIDS, by an odds ratio of 4.1. That means the effect of having infants sleep on the front or in the front position increased the risk of this syndrome by 4 times. So that is considered a large effect. A relative association measure more than 2, meaning the effect is more than double, that is considered a large effect. And that should increase your certainty in the evidence, meaning you're more certain that there is an effect. So even if there's confounding and bias, we believe that if the intervention increased our outcome by 4 times or 4-fold, it's unlikely that this bias has actually caused all this 4-fold increase. So it tells us that there's perhaps a true signal there. That's the concept of large effect. The other one is the concept of dose-response gradient. So if there's association between the rapidity of antibiotic administration, for example, and survival, if we see in patients who come with septic shock or sepsis, and we give them antibiotics, and then we see whether they survive or not. So if we see that the faster we give the antibiotics, the more survival we have, then that can increase our certainty in the observed association. This bar graph here shows that survival and survival fraction, which is in the black columns, goes down as the time for giving antibiotics goes up, which are the gray columns. So this is the dose response effect. This increases our certainty that there is a true effect. And then the last and third observation that makes us increase our certainty in non-randomized studies is this concept of favorable confounding. The example given here is it was shown that non-for-profit hospitals have lower mortality than for-profit hospitals. So like a county hospital here in this study had lower mortality than a private hospital. So this is obviously not a randomized study, and we know that there is huge confounding in that sicker patients are more likely to go to the county hospital, the non-for-profit hospital, but despite that we're seeing that non-for-profit hospitals are doing better. So despite this confounding, we're seeing an effect. This increases our certainty in the effect, despite the confounding. So the confounding here is in a direction that actually increases our certainty. So I presented to you the GRADE framework that recognizes the importance of observational studies and gives you these three elements by which you can increase your certainty from observational studies. Based on this classic evidence pyramid in which observational studies are in the bottom, then you have randomized trials, and then you have systematic reviews and meta-analysis on the top, it really doesn't make a lot of sense. And the way we'd like to modify that pyramid is by doing two things. If you look here, we made the lines wavy between the different study designs, which means this basically is GRADE. It means that a case control study may be better than cohort study in some situations, which may be better than randomized trial in some situations. So these wavy lines imply that there are other factors beyond study design that can affect our certainty. And then we chopped off the top of the pyramid by removing systematic reviews and meta-analysis outside of the pyramid. So this is the final pyramid after modification. You see that the systematic reviews and meta-analysis are chopped off the top, and they have become a lens through which we appraise and evaluate and apply the evidence. So they become a tool. And then you see the wavy lines in the pyramid, which refers to GRADE. In summary, GRADE is a framework that recognizes the importance of non-randomized trials for decision making. GRADE rates the certainty of evidence using factors other than randomization, and GRADE is conducive for decision making in situations where non-randomized evidence is the best evidence available. The second theme I would like to talk about is a tool for risk of bias assessment called the Robbins eye. This is a tool to evaluate the risk of bias in non-randomized studies of interventions. The risk of bias of non-randomized studies is considered high as a starting place. However, by using this new tool from Cochrane, this tool, the way it works is that you basically imagine there is a hypothetical trial that answers the same question. And then you look at the observational study and see how this study is different from that randomized trial. So it's a different way of thinking of starting. Typically we start with low expectations for observational studies, but here we're starting high and then we're going down. So instead of starting low and going up, we're starting here high and going down. The tool compares risk of bias across 7 domains. And conceptually, if you apply this within the context of GRADE, you can start with observational studies as a high quality evidence, and then you can go down based on specific confounding and specific biases that you can detect. This is the tool and its 3 domains of bias: pre-intervention, at intervention, and post-intervention. The limitations of this tool is that it's not validated or used widely. It's still fairly new. And then there is a possible misuse where people can actually give more credibility to confounded evidence. The third framework I would like to discuss is this one, which I call complementary, sequential, or replacement. So this is a framework by Holger Schunemann et al. And basically this tells you that when you should use non-randomized studies, and it gives context for randomized studies in which they can be classified as complementary, sequential, or replacement for evidence provided by randomized trials. Here I show with an example how this framework works. So there's a randomized trial that compared hydroxyurea in adults with sickle cell anemia. The trial showed reduction in pain crises, acute chest syndrome, and transfusion need, and also looked at some surrogate outcomes such as hemoglobin F and hemolysis. The trial followed patients for a mean follow-up of 21 months. So this is the randomized trial. Let's think about now about observational studies that can fit as a complementary, sequential, or replacement evidence to this trial. So looking at complementary studies, so there are observational studies that explain why people do not take hydroxyurea. So trying to explain or improve poor adherence to hydroxyurea. There are studies that discuss the barriers and facilitators of adoption of hydroxyurea in routine care, and studies that are showing differential benefit in certain patient groups. All these observational studies can be used as complementary evidence to the RCT. In the other category, there are observational studies that showed the effectiveness and safety of hydroxyurea after long-term follow-up. So remember, the trial lasted had a mean follow-up of 21 months. This is a long-term treatment, so the observational studies that followed patients for a longer time, these can be called sequential evidence. Also studies that correlated changes of hemoglobin S and F, which are the surrogate markers with clinical outcome. This is also called sequential. So the trial used surrogate outcomes. The observational studies showed good correlation of these surrogates with clinical outcome. Those types of observational studies can be called sequential, which is the second category. The third category is replacement. So in the original trial, the patient had sickle cell anemia and they had either hemoglobin SS or S beta thalassemia. Now there are other types of sickle cell anemia and sickle cell disease with other genotypes, such as the ones here listed on the slide. So observational studies that showed benefit of hydroxyurea in these groups would be considered replacement evidence, because it replaces the evidence from the RCT when we are dealing or providing care with patients with other genotypes. So this framework actually is very good. It helps you think of observational studies as complementary, sequential, or replacement for randomized trials. Another framework that you can think about when dealing with non-randomized studies is to think about situations in which observational studies are needed for comparative effectiveness research. And there are 6 situations here. The first one is when larger studies are needed, and the example given here is intravenous versus oral steroids for COPD or chronic obstructive pulmonary disease. So some of these studies estimated that you need 60,000 patients actually to have a randomized trial, which is not feasible. So when larger studies are needed, would be one situation. The second one is when treatment adherence is a major concern. So inhaled corticosteroids were shown to be more effective than leukotriene modifiers for asthma. But inhaled corticosteroids have very low adherence because patients find them more cumbersome to take compared with the leukotriene modifiers, which are pills. So lower adherence leads to worse outcomes. So although the trials will tell you that the inhaled corticosteroids are more effective, observational studies may show you the other way around, because they are actually looking at the real world perspective and whether patients were adherent to treatment or not. So when treatment adherence is a major concern, observational studies will be needed. One way we have used observational studies in the same context of the Bayesian framework or in a similar context is to get absolute effects, to model absolute effects. Absolute effects are needed for decision making, and by absolute effect I mean things like a risk difference or absolute risk reduction. These are the numbers that clinicians and patients understand. They are needed to individualize care, but randomized trials usually give you a relative effect, so they give you like an odds ratio or relative risk. So one way to combine the two is by using baseline risks for individuals at various risks from observational studies or from your own data, from your own health system data, and multiply that by the randomized trial relative risk to get an actual risk for patients in different subgroups. This formula here shows how a CAR, which is the control event rate, that you can get that from an observational study, and then you have the odds ratio that you get that from a randomized trial, and using this simple formula you get the risk in people who have received the intervention. This way you can provide an individualized risk information for different patients. The idea about using observational studies to provide a prior in a Bayesian framework is actually very intriguing. So following a Bayesian framework of thought, you have a prior belief, then you do the trial and get what's called a likelihood ratio or evidence, and then you have a posterior belief, which is the way you believe after the trial results are out or after the experiment is done. So it could be that the real world data or observational studies will give you the prior belief, and then you conduct your trial, which will modify this prior belief into your posterior belief. And there are examples of where this actually can be implemented. The fifth important framework here in talking about real-world data or non-randomized studies is to think about these studies as a tool that can aid in randomized controlled trial design. So the observational study or the real-world data generated from electronic medical records can help in the selection of sites for randomized trials with high enrollment, provide basis for power calculation, and selecting patients at risk, providing a prior for Bayesian analysis, and providing external control groups. So more to aid in research and study design. In summary, this framework that I presented is a way of thinking of observational studies and when they are needed for comparative effectiveness research or for decisions. And these are 6 situations that I gave examples to you about. They are when larger studies are needed, when treatment adherence is a concern, when provider training is a concern, when treatments are off-label, when the condition is changing, and in urgent situations. The fifth situation in which observational studies are needed for comparative effectiveness research is when the conditions are changing. So randomized controlled trials have supported the use of live influenza vaccine, and the ACIP has issued preference for it in influenza season 2014-2015. But observational studies of vaccine efficacy showed something different. And then the ACIP removed their preference for the live vaccine in the year 2015-2016. And again, the following year, observational studies showed no efficacy for the 2009 H1N1 influenza virus. And because of that, the ACIP eventually recommended against using the live vaccine in the influenza season 2016-2017. So this example shows you how when the condition is changing, randomized trials may not be the best evidence, and you need observational studies that can follow this change and give you more real-time data. And this example just shows that. The last and sixth situation when observational studies will be needed is when the condition is urgent or emergent, such as Ebola. And I think this is very intuitive. You cannot wait for randomized trials when you are dealing with an endemic or pandemic disease like that. Another situation in which observational studies are needed is when providers' training affects outcomes. The example here is about implanted defibrillators, and they can be implanted by electrophysiologists, general cardiologists, or surgeon, and it was shown that the complications and the outcomes depend on who places the device. So if you have a randomized trial that has a very controlled and rigid environment, and they probably used electrophysiologists in it, those results may not be helpful to real-world practice, and you really want observational studies that tells you what are the outcomes when non-electrophysiologists have placed the device. The next situation is when treatments are off-label. The example here is randomized controlled trials showed that drug-eluting stents were better than bare metal stents, and the FDA issued approval for drug-eluting stents. Then case reports showed that mortality and thrombosis were high in drug-eluting stents, which made people rethink, well, did the randomized controlled trials get it wrong? So we had that situation, but in observational studies where they're critical in showing that really the change in outcomes was more attributed to the off-label use of stents in sicker patients. So you were seeing more of these drug-eluting stents placed in sicker patients, and that's why their outcomes were worse. So how good are these methods? Some studies compared them, and the same analysis was done by propensity score and instrumental variable analysis. 42% of the time the results were non-significant for one method and significant for the other method. So it's a big problem. Almost half of the time you have no consistency between the two methods. The instrumental variable analysis was non-significant in most situations. So it seems that it's biased more towards the null. Regardless of the method, adjustment does not eliminate confounding in observational studies. So to date, we do not have a good method to reduce the problem of confounding in real-world evidence or observational studies. The last framework is actually a counterpoint. So it's just discussing, can we reduce bias through analysis? We know that big data is likely confounded, but there are various statistical methods that can use to reduce confounding. We're all familiar with multivariable adjustments using regression, but there are other methods such as propensity score matching and instrumental variable analysis. So propensity score matching in a nutshell is where you predict the assignment of each data point by using the available covariates. So if you have patients who were assigned to 2 treatments but not at random, you can try and calculate the probability of each person being assigned to the treatment. And you use regression to predict these propensity scores, which are the probability of assignment. And then you can match subjects with similar assignment probability, trying to make everything similar except the intervention. The instrumental variable analysis, this is when we use an instrument external to the regression equation. So we use a variable that is not part of the equation, but it's associated with the intervention. And by using that, we hope to reduce the confounding. For example, if you are comparing smokers and non-smokers, or obviously they're not randomized, but perhaps instead of smoking status, you can use smoking tax, for example, as a surrogate for smoking. This way, you can try and separate yourself from the other variables in the regression equation. For another example is to use distance from a medical center that offers cardiac catheterization. So using this distance as a surrogate instead of the intervention itself. So these are ways to separate the confounder from the actual intervention. This is the consistency framework that I mentioned earlier, and this is to help us with the decision of whether we want to combine randomized and non-randomized studies in meta-analysis. So this depends on consistency, where you have the observational studies on top, and then the randomized trials in rows. So you have, it's like a 2x2 table. So if you look at the top left square, you see that you have inconsistency of randomized trials and inconsistency of observational studies. So both are inconsistent internally. So here is a situation where you cannot really do meta-analysis. It doesn't make any sense unless you can stratify the studies by some covariate. Like here, they stratified the studies by whether they enroll patients who were at high risk or medium risk or low risk for the outcome. Once they're stratified like that, we see complete consistency. So if you see the situation where there is inconsistency in trial and inconsistency in observational studies, you can try and stratify, otherwise the meta-analysis is not valid. If we go to the square in the left bottom, this is where trials are consistent and observational studies are not consistent. So here a meta-analysis of trials is valid, and then the observational studies can be just used for context and providing contextual information, but they cannot be fully meta-analysis. If we look at the top right, we see that the trials are inconsistent, but the observational studies are consistent. In this case, the observational studies can be pooled in meta-analysis, and we would evaluate every body of evidence on its own. We can use GRADE and see which one offers more certainty, and we can go with the body of evidence that has the highest certainty. In the bottom right, there is consistency of the trials and there is consistency of the observational studies. That gives two types or two situations or two scenarios. The top one is where everything is consistent and you can pool observational studies and randomized trials in meta-analysis. The bottom one where every study design is consistent within itself but not consistent with the other. There you can do meta-analysis for each separately and rate the quality of evidence and see which body of evidence offers more certainty and use that for decision making. You see here the randomized studies in the first figure on the left, and then the non-randomized studies on the right. The studies risk of bias is demonstrated in the colored figure, but you see that the randomized trials have shown a relative risk of 0.92 that was not statistically significant, suggesting that probiotics reduced sepsis. The non-randomized trials also showed a similar effect, which is non-significant reduction in sepsis. So is the meta-analysis here valid or not? Because you see that the results are consistent between the two, but both of them are borderline significant, and if you add them, you can get significant results. The seventh theme is about pooling randomized and non-randomized studies in meta-analysis. Some people consider this absolutely wrong. Some people do it. And there are different approaches to doing this. There's a new framework that's focused on consistency, so consistency in results. The example here I will give is about probiotics in preterm infants to reduce neonatal sepsis. An example of the concept of registry trial is the thrombus aspiration in myocardial infarction trial, what's called the TASTE trial. This depended on a high quality registry that already existed, by which investigators randomized patients who would be in the registry anyway. So they were able to quickly enroll thousands of patients in little time. They avoided long case reports and forms, and they had accurate follow-up with minimal effort. So the findings were broadly generalizable because they are using patients from the registry, which includes patients from the whole country, and the cost was only $50 per participant, because the cost was just for the randomization, but everything else was going to happen anyway. So the intervention, the follow-up, all that, data collection, that all will happen anyway, and the only piece that was added was the randomization. The sixth theme is about the randomized registry trial. This is an innovative design that builds on existing registries in which all baseline data and follow-up are already being collected. So we can only add the randomization piece, and we have an open, pragmatic design of a randomized trial. It's questionable in the US, except in areas where we have established registries, like registries for devices, for angioplasty, for cancer, like cancer registries. So these would be good areas where you can implement this randomized registry trial approach. In Europe, probably it's easier because there are health systems that are more closed, and you can capture more patients. The last slide here is this published study, and you see the study design in the first sentence of the methods there, labeled as a retrospective randomized study. So I'll leave you with this. Think about what randomized study can be retrospective, and this is just a reminder that these study labels are used by people inappropriately very frequently. So can a randomized study be retrospective? The trivia is about the impact of study design on the news. So comparing RCTs versus non-RCTs, published in the top 7 medical journals in 2013, showed no difference in coverage by major newspapers or news agencies. So the lay media doesn't really care about randomized versus non-randomized. Large RCTs reporting hard outcomes like mortality did not generate more news coverage than small RCTs with surrogate outcomes or observational studies. So again, the media doesn't necessarily care about the study design. They are attracted by other things. However, RCTs were more likely to attract a journal editorial. So the medical community likes RCTs, whereas news media, they don't really care. In summary, observational studies, particularly in the form of big data or real-world evidence, are a rich source of information not to be ignored. I showed you various approaches to integrate them in decision making. None is perfect, but I would like to highlight GRADE, because GRADE is a method to rate certainty in the evidence and develop recommendations, develop action, and GRADE gives credibility for observational studies and provide a framework to actually evaluate certainty of evidence from observational studies. The other one is this complementary, sequential, or replacement model. This tells you when to use observational studies and put them in context with the randomized evidence. This ends the talk. I do have a quick trivia slide and then a puzzle. Good morning. My name is Hassan Murad. I am a professor of medicine at Mayo Clinic, and I direct the Mayo Clinic Evidence-Based Practice Center. I am a clinical epidemiologist, and my area of interest is guideline development.